Hello, my name is Dr. Christopher Blackwell. I'm an acute care nurse practitioner, associate professor, and program director for the Adult Gerontology Acute Care Nurse Practitioner programs in the Department of Nursing Practice and the College of Nursing at the University of Central Florida. I'd like to welcome you to the third part of a 5-part narrated PowerPoint series on neurologic and neuromuscular healthcare problems. This is a 2020 update. So this is an update in this particular content material to reflect the most recent guidelines that were written in 2018, in late 2018, by the American Heart Association and the American Stroke Association on acute management of cerebrovascular accident, which is looking like an outdated term, and we've gone back to the use of the word stroke. So we're going to talk about different neurologic and neuromuscular healthcare problems, and this is a little bit of a different type of update than for other units that you might see in the course. For other units in the course, you might see where I've left the old material in place and just provided an updated lecture, so there's another additional lecture added to the unit. In this particular unit, what I've done is deleted the old material that was no longer relevant and completely updated it with the new material. So this is an entirely new slide deck, an entirely new presentation that I've worked hard on putting together for you that reflects the most current and recent evidence-based practice on managing neurologic and neuromuscular healthcare problems, specifically cerebrovascular disease and emergencies. This is a pretty cool piece of data to kind of start out with. So many of you are familiar with the term transient ischemic attack, or TIA, and we're going to talk about TIA in the first part of this lecture. And if you look at, these are 2016 data. These were the most recent data that I could find looking at the presence of TIA, the presentation of TIA, and what is it in terms of predictive value that a TIA event or a minor stroke event will have on significant cardiovascular events, including stroke, a year later. And then looking at it again, years 2 through 5. So these particular data, the points that you see here, looked basically at what the risks were for patients who had a TIA or minor stroke as initial presentation, and then at 1 year, what did they present with in terms of, hang on one second, we're going to get rid of these and go back to this slide. I had the there we go. Okay, so I had the advanced timer on, so I had to turn that off. Anyway, so basically looking at presentation of TIA, and then 1 year later, what was the likelihood that that person would have a serious cardiovascular event, including stroke? And what we found was about 6.4% of these people within a first year after a diagnosis of TIA or minor stroke would go on to have a major cardiovascular event. But what's interesting to note is that those same people who presented initially with TIA in years 2 through 5 also only had about a 6.4% risk of a major cardiovascular event, including stroke, during that time period. So that's pretty interesting, because I think traditionally speaking, we've always thought of the numbers being a little bit higher than that, of TIA being a major predictor of stroke. And you might be thinking to yourself, well, geez, Dr. Blackwell, why is that? Why is it that in 2016 we're seeing, actually I have a 2018 reference here that I found, so I had initial data here from 2016, and then I was able to follow up with a more recent article from these same authors in 2018 that showed this 6.4% statistic. And you might be thinking to yourself, well, geez, why has there been this change? Well, I want you to think about that. In more recent medical history, a patient presents with TIA, we now know that those patients are at risk for developing severe cerebrovascular accident or going on to develop other cardiovascular events. So what are we doing? We're recognizing those patients a lot earlier, and we're putting them on intervention quickly so that we can stave off a serious cardiovascular event in the future. So while in the past we've thought of TIA as being a major predictor of stroke in the next year or in the next several years, what we found is that by getting these people recognized early, getting them referred to neurology, getting them on a statin, getting them on an antiplatelet or other type of treatment, that we were able to improve outcomes significantly. And the data are telling us that. This 2018 data are definitely reflecting that change. If you want to pause the slide presentation at this time and just take a look at these graphs, you're more than welcome to do that and read the legend on the right. Pretty interesting information that's presented here. So brain ischemia, let's talk about the overarching theme here of brain ischemia, and then we're going to go back and talk about some more specific stuff. So ischemia may be transient, like we talked about, for example, in a TIA, or it may persist for a longer period of time. And symptoms and signs persist with irreversible brain damage and infarction. So the old adage of time is tissue remains tried and true. Time is tissue. The longer a patient has brain ischemia, the more longer the tissue is going to be infarcted, and the more neurologic symptoms and sequela the patient's going to have in the long run. In an acute presentation, neurologic symptoms are not necessarily accurate indicators of infarction. You may not actually see the neurologic sequela and damage until several days after the infarct has taken place. So you may not be able to look at an infarct or look at the symptoms and say, well, this is an indicator of the degree of infarct the patient's presenting with. The symptom rate does not indicate ischemia cause as well, and treatment depends upon accurately identifying the cause of symptoms. Very, very important. When we break apart cerebrovascular diseases, we can basically lump them into one of two major categories. The first is ischemic, and ischemic stroke makes up about 87% of all cerebrovascular diseases. And it used to not be that much. We used to think it was about 80-20 in terms of ischemic versus hemorrhagic. But the most recent data, epidemiologic studies on this has shown it's actually more like 87-13, and I actually just pulled those data from the Centers for Disease Control, and they were 2019 data when I was putting this lecture together. But ischemic causes are inherent in the vessel. So they're things like atherosclerosis, right? We all know what atherosclerosis is, lipid deposition within the tunica intima, which results in bleeding, damage, mass accumulation of platelets and other coagulatory factors that go into the vessel and cause it to clot up. The inflammation that can be related to that, dissection, which can be caused by significant weakening of the vessel over a long period of time as a result usually of uncontrolled hypertension, malformation like AVMs, for example, which we're going to talk a little bit about on the hemorrhagic side as well, aneurysmal dilation or venous thromboses. They usually start remotely, or I should say they don't usually, but they can start remotely, and then in that case, it becomes an embolism. And probably the classic example of an embolism that can result in ischemic stroke is going to be someone with atrial fibrillation who develops mural thrombi. They throw off those mural thrombi, and then the mural thrombi get lodged into one of the cerebral arteries, causing a massive stroke. So that is an emboli or embolism example. And then the other cause of ischemic stroke can be due to inadequate cerebral blood flow, which results from decreased perfusion pressure or an increased blood viscosity. So you might see, for example, sickle cell anemia, that being a major cause of stroke in people who are inflicted with that particular disease. Or you get patients who are in shock, for example, hypovolemic shock, or they're exsanguinating and bleeding out. They'll have inadequate cerebral perfusion pressure, and so they'll have a stroke event as a consequence of that. And then on the other side of the coin is your hemorrhagic stroke. And this happens when there's a major vessel, usually in the subarachnoid space or the intracerebral tissue, that ruptures. So that vessel breaks open, either from an AVM or an aneurysm, or just a really weakened wall that develops over time with that chronically uncontrolled hypertension, for example, and that vessel bursts open and the patient develops an ICH. Very serious diagnosis that requires immediate surgical intervention to save that patient's life. The major difference that you see, and I've got this as one of the points here, is you tend to see these hemorrhagic events in younger patients versus the ischemic events in the older patients. And the reason for that is it takes time for that atherosclerosis, that arterial damage that occurs on the ischemic side of things before the patient actually ends up having a stroke. Versus hemorrhagic, some of those things can be precipitated by other behaviors and other things that will cause a brain hemorrhage. I'm thinking off the top of my head, for example, inhalation injury that can occur from like cocaine abuse, for example, which can cause a massive vasoconstrictive event, and that massive constriction damages the vessel so much that when it finally relaxes and dilates, it'll blow the vessel open because of that sheer pressure on the vessel. Or people that use inhalant drugs like poppers, or I'm trying to think like spray paint, those types of crazy things that people oftentimes will breathe in. They'll get a brain bleed as a consequence of that. So all those things are causes of hemorrhagic events as well. So when we started talking about TIA, showed you some data on TIA, and I think TIA is a really good place for us to start. The original definition was introduced in the 1950s, and it was a brief focal loss of neurologic function due to a temporary cerebral ischemia that often precedes strokes and lasts less than 24 hours. What we found was that was a pretty general, non-specific, and not very intelligent way of looking at these events. So in 2009, the American Heart Association and the American Stroke Association updated their definition of transient cerebral ischemia, and I'm going to introduce you to some more terms on this in just a few minutes. But that basically said that it was a transient episode of neurologic dysfunction caused by focal brain, spinal cord, or retinal ischemia without acute infarction. So people often think of TIA being, or even stroke being just a brain ischemia, but it can be retinal as well. And one of the few cases in my career where I've had to manage an acute stroke patient in the ICU was in fact a retinal ischemia that I had to help manage. And it's treated the exact same way that you treat a regular stroke. I mean, it's treated with TPA. It's treated with the clot busters, and you use the exact same protocol for that treatment. And the benefit of that 2009 definition was it gave us a biologic versus time endpoint. So it really changed the focus instead of this less than 24-hour argument to really looking at tissue function and that transient neurologic dysfunction as being the main defining aspect. The 2018 guidelines by the AHA and the ASA continue to use the term TIA. In the old lecture for this, I identified that was no longer in the 2009 guidelines, but the 2018 guidelines do in fact continue to use that term throughout, and I'm going to show you another term that is emerging in the literature, which is this acute cerebrovascular syndrome, or ACVS, and it's very similar to the acute coronary syndrome that we've termed recently in terms of chest pain and cardiovascular ischemia in terms of the brain. So this newer emerging term of ACVS is really what's coming about into the literature now. So you're going to be seeing this term a lot more than TIA or transient cerebral ischemia. You're really going to see this more global term of ACVS. And ACVS is defined basically when a focal symptomatic reversible ischemia occurs in the brain. We call that a TIA. And when a focal symptomatic irreversible ischemia occurs in the brain, we call it AIS. And then this ACS, they share a single pathophysiological mechanism that is rupture of unstable plaque followed by formation of platelet-rich thrombi which plug up the coronary arteries, and that's kind of the similarity it shares here, because that same pathophysiologic process that occurs in the coronary arteries resulting in MI is what's occurring in the brain that's resulting in either a CVA or this new term of AIS, if you will. Unlike ACS, the mechanism of ACVS is a little more complicated. It's not only large artery atherosclerosis, which is similar to the ACS, but also that cardioembolism, which I talked about just a minute ago. And those cardioemboli, those mural thrombi, tend to result in more small vessel occlusion versus the more larger vessel occlusion that you get with the atherosclerotic events. In addition, there are no measurable biomarkers for ACVS, while there are particular biomarkers for ACS. So for example, we can't get a troponin level and say, oh look, the troponin level is really high, so the patient's had a stroke. Right? We can do that in MI, right? We can actually track the biomarkers of troponin and to a lesser extent CKMB and some of the other cardiac enzyme assays and say, oh yeah, definitely the patient appears to have had a myocardial infarction. Unfortunately, we just don't have that luxury in the brain. We don't have any real measurable, hormone or anything in terms of biomarker that the brain gives off when it becomes ischemic. But nevertheless, the concept of this ACVS is practical to emphasize the importance of immediate evaluation and starting treatment to prevent subsequent stroke in acute settings of TIA. So therefore, TIA in acute settings as well as this AIS should be recognized now as ACVS, and it's a medical emergency. So what's the takeaway point from all of this? Takeaway point, new emerging term, ACVS. It's very similar to ACS. We treat TIA, we treat acute ischemic stroke as medical emergencies. This causes the red flag to go up. Patient presents to the emergency department. They're time sensitive. They're tissue sensitive. We need to start interventions right away. This is a medical emergency. So let's go back and continue talking a little bit more about TIA. Like I mentioned, or TCI, like I mentioned, the new modern definitions are more based on tissue versus time. So the endpoint is now biologic. It encourages the use of neurodiagnostic tests to identify brain injury and cause, and the presence or absence of ischemic brain is more accurate for this particular diagnosis. The AHA and the ASA did not incorporate the phrase typically less than 1 hour in the new definition, and there's really no reliable time cutoff to distinguish if symptomatic ischemic event will result in an ischemic event, or an infarction, I should say. So really what that's telling you is that it's not a good idea necessarily to look at time and to look at TIA in terms of this being such a short event that we don't know there's going to be any neurologic sequela. So a patient presents, you don't usually know that it's a TIA until days after the event's taken place, because you don't have any sequela. You don't have any carryover that looks like, yes, there's been cerebral infarct here. So until those days have gone by and the patient's had a chance to recover fully, you don't really know if it's a TIA or if it's in fact a stroke. So that's the real takeaway point here, is that we treat TIA and acute stroke as basically the same thing. They're the same entity. We're going to treat them the same way. We won't know if a TIA was a true stroke until a few days later or sometime later, and the patient has had time to recover from that event. There was one other thing I wanted to tell you about TIA, and it's skipping my mind right now, but it will come to me in just a second. Okay, hopefully it will come to me. If not, I will come back to it. Okay, so this is a very common problem. About 200 to 500,000 cases in the United States on an annual basis. Blacks and men have more prevalence for this than whites and women. The other thing I found combing through the most recent epidemiologic data, there are higher rates in rural environments versus urban settings. I found that to be of interest because, as you probably know, rural health presents challenges, and it's very difficult sometimes to get the high level of acuity and the high level of care necessary in rural settings as it is in urban settings. So not only are the rates higher, but then, and I don't have the data on this, but I would guess that the outcomes are probably a little bit poorer in rural versus urban settings as well. The reported incidence is about 29 to 61 per 100,000 in Western countries. And we talked about there is an increased risk for recurrent stroke, and transient events with neuroimaging evidence of infarction have a high risk of being then diagnosed as an ischemic stroke. Transient cerebral ischemia is a neurologic emergency. We've already established that. And early recognition of TCI can lead to early preventative therapy or even a revascularization procedure, which we're going to talk about briefly in this lecture. So the most recent data that I was able to find, I pulled from the CDC website in 2019, and it looks like some of the data were from 2016, like the figure that you see on the right here, and then the stroke facts that I found were a little bit more recent. They were from 2019. But stroke dropped to the 5th leading cause of death in the United States, and the reason why that's probably happening is because early intervention is resulting in our ability to recognize the symptoms. We're going to talk about FAST and some other ways that we recognize the symptoms of stroke. But not only recognize that, but do some early interventions. Either get them into revascularization, get them on TPA, do what's necessary to get them better. The other thing is, like I mentioned before, acute coronary syndrome and a lot of the pathophysiology that occurs with ACS is mirrored here with ACVS. And so as a consequence of that, patient has a cardiac history or has hyperlipidemia. Sorry, I'm trying to adjust the microphone here so it's a little more comfortable. Okay. Those patients are going to be put on, for example, statin therapy pretty early. And we know that those same anti-inflammatory and anti-lipid effects of those drugs is going to have the same type of effect in the coronary arteries as it's going to have in the brain. So with the use of statins and other preventative type approaches, we've certainly improved outcomes and chipped away at that as being a more higher cause of death. Recognition that TCI was really an ischemic event is also something that has led to improved outcomes. So what are some facts here? So stroke is, like I said, the 5th leading cause of death. It kills about 140,000 Americans each year. That's 1 out of every 20 deaths. A stroke, sometimes called a brain attack, occurs when a clot blocks the blood supply. We already know that. Or it can be hemorrhagic, where the vessel bursts. Someone in the U.S. has a stroke every 40 seconds. Every 4 minutes, someone dies of a stroke. There are about 795,000 people in the United States that have a stroke each year. About 610,000 of these are first or new strokes, and about 185,000 are recurrent. It's a very important cause of disability. In fact, on the old lecture I had for this, I had some data that showed it was the #1 cause of disability in the United States. I was not able to find any data to continue to support that, so I took that off of this updated lecture. But in the past, it was identified as the #1 cause of morbidity and disability. Stroke reduces mobility in more than half of stroke survivors age 65 and older. It's about $34 billion in cost to our healthcare system annually. And there are different factors that we're going to talk about that are, some of them are more modifiable than others, but there's certainly some risk factors that we can look at in terms of reducing the risk. So this is the anatomy of the cerebral arterial circulation. You can see that here on the left. You've got the anterior communicating artery here, A2, A1, M1, P2, P1, all of that outlined. Let me get my arrow out. Oh no, let me go back. Sorry. Here. And the basilar, internal carotids, the vertebral, the common carotid here, subclavian, and then your aorta down here. And you really have to think about in terms of surface anatomy and where that feeds the brain. Anteriorly, you have your 2 carotid arteries. Posteriorly, you have the posterior vertebral arteries, and then in the brain, those main bifurcation, well, that's not the right term, but those main arterial branches, if you will, join to form what's called the circle of Willis. And the circle of Willis has these tributary branches that break off and then feed the actual brain tissue itself. When brain ischemia occurs, first of all, it's a syndrome. And there's 3 pathophysiologic mechanisms that occur. So you can have large artery flow ischemia. So you get low flow ischemia, basically. It's brief and recurrent, often associated with a stenotic or atherosclerotic lesion. The internal carotid artery is often the origin, or the intracranial portion can be the origin. And the middle cerebral artery stem, or at the junction of the vertebral and basilar artery, can also be where these lesions like to hide out. Any obstructive vascular process in the extracranial or intracranial arteries of collateral flow to the potentially ischemic brain also is impaired. So those are all really important facts when looking at this large artery, low flow ischemia. This is the anatomy of the cerebral arterial circulation. You can pause the video at this time if you'd like to just review the anatomy for this, because as we move forward, I'm going to tell you where some of the most common strokes occur, in which vessels are affected, and what symptoms you're more than likely going to see in your patient that presents to the ED. Now, in all honesty, You're going to learn these. We're going to talk about them. I'm going to try to reinforce them. They are on the board exam, so they do expect you to know these things on your board exam. But when you get into practice, really the thing I've tried to impart on you guys from day one is, as long as you know how to do a really good, comprehensive neurologic and neuromuscular, I should say, exam, which consists of your 12 cranial nerves, and on top of that, looking at muscular function in terms of strength and symmetry. And as long as you're able to apply that knowledge, you're going to be able to see right away that there is definitely some type of ischemia going on. In an acute presentation or in a chronic presentation, then this is a sequela of a neurologic event that's occurred before. So probably the most paramount thing for you to know as an acute care nurse practitioner is how to perform a really good neurologic exam, looking at your 12 cranial nerves, and then also knowing how to look at muscular assessment and neuromuscular assessment. Identifying, wait a minute now, the right is not equal to the left, there's ulnar drift in the arms, there's, definitely, when I ask the patient to shrug the shoulders, right, I check cranial nerve number 12, for example, I ask the patient to shrug the shoulders, the spinal accessory nerve, definitely, that's going to be important. I think I said that, though. That is hypoglossal is actually cranial nerve number 12. So the accessory nerve is what I was talking about. But nonetheless, those are all things that as long as you know how to do those assessments and you see right away that there's a problem, then you know as a practitioner that you need to do something about it. And this is this is important here. So this is the middle cerebral artery distribution and the signs that you'll get when you've got an occlusion. So you might see something like, for example, paralysis of the contralateral face, the arm and leg, sensory impairment over the same area, motor aphasia, central aphasia, word deafness, anomia, jargon speech, sensory agraphia, acalcula, all those types of things here on the left are symptoms of an occlusion. And if you look, let me get my arrow out again. Okay, so if you look at these signs and symptoms, you can look and see exactly where you're more than likely going to find that. Where is this being affected physiologically, for example? So your motor aphasia obviously is going to be in your motor area of your brain, the motor speech area, which is going to be your Broca's area. So, obviously that's going to be very, very important. So this middle cerebral artery distribution, you can see here from the diagram, it's quite extensive. So any kind of occlusion in the middle cerebral artery, you're really going to have some significant neurologic presentation as a consequence of that. And you can also have superior pontine syndrome, where you can get occlusion in this area of the brain and the resulting neurologic sequela that are involved here. I'm not going to read these all to you, but if you'd like to pause at this time and read this, I would recommend that. I think that's important to do, and just kind of realize where in the brain physiologically these things are happening and what are the presentation. For example, one of the things that you'll notice, let me get my arrow back out, one of the things you'll notice about the pontine syndrome is there's a lot of cerebellar tissue which feeds off of this area, right? Well, what is that cerebellum doing? It's maintaining balance for you. Okay, when you walk and your hands, move, or your arms, I should say, sway lightly back and forth to help maintain your balance, that's being involuntarily coordinated for you by the cerebellum. So if you have an infarct of the pontine tissue, that's going to result in cerebellar occlusion, or tissue being affected, I should say. So what do you think the most common presentation of this is going to be? Look at the very top. Cerebellar ataxia. So that, again, ataxia is going to be a repeated finding in all of these pontine type of lesions or pontine type occlusions. And then the anterior cerebral artery distribution, you can see here as well, is quite extensive. Look at all the branches off of the anterior cerebral artery, and you can see these are going to be much more specific. Things like paralysis of opposite foot and leg. You're going to have some slowness, delayed, intermittent interruption, lack of spontaneity, those types of things that are going to be more prevalent in an anterior cerebral artery distribution. So posterior cerebral artery distribution has its own branching out and its own areas of involvement as well. And oftentimes in the posterior cerebral distribution, you think of that maybe being more in the occipital region, right? Well, what's in the occipital region? It's your visual cortex, right? Look at the top presentation in the peripheral territory, guys. Hemianopsia, right? Where you actually have this blindness in half of the visual field. So you can see that visual disturbances are going to occur oftentimes with a posterior cerebral artery occlusion. So really, like I said, going back to what I said here, right? Looking at the anatomy here, and then looking at the middle cerebral artery distribution, the pontine syndrome, anterior cerebral artery distribution, and your posterior cerebral artery distribution, the takeaway point is still going to be, like I said before, 12 cranial nerves will never fail you. If you know how to properly do assessment of your 12 cranial nerves, you're going to pick this stuff up. So if I don't have an intact gag reflex, for example, right, where I am assessing the cranial nerves 9 and 10. If I don't have a good seal of the mouth when I ask the patient to puff the cheeks and smile real big, right? I'm checking cranial nerves 5 and 7 when I do that assessment. I can see right away asymmetry in the face. I know right away, my gosh, this is not good. This is an acute presentation. This is a CT scan without contrast immediately, so I can find out if there's an infarct going on here. So again, your 12 cranial nerves are tried and true. They will never fail you. But you've got to also add to that looking at neuromuscular function. And a great example of that was, for example, anterior cerebral artery occlusion, where we would look, for example, I would say to the patient, okay, I'm going to put both of my hands on the bottom of your feet. I want you to push on the gas on both feet. Here we go. 1, 2, 3, push as hard as you can. Well, if I have paralysis on one side, let's say on the left side, then I may have a right-sided anterior cerebral artery infarct or occlusion taking place. So those are all things that are going to be caught in my neuromuscular and my neurologic exam. So that was the first thing, this flow issue or low flow as being one of the main pathophysiologic processes associated with brain ischemia. The second one is embolic. This is discrete. It usually occurs in a single site. It's more prolonged, so the symptomology occurs for a longer period of time. The embolus may arise from a pathologic process in an artery, so that usually is extracranial. So it could be, from example, like I mentioned before, the heart, so AFib or a left ventricle thrombus. And you want to search for the source. Why has the patient developed an embolism? What is the cause here? Emboli don't just spontaneously occur. There's got to be some type of coagulopathic disorder, some type of a cardiac disorder or other type of event that is occurring here that is resulting in this embolic event. So we got to search for the source. We can't just treat the we can't just treat the symptoms. We have to look for the cause. The third is a lacunar or a small penetrating vessel, TCI. This is where most of your transient events are going to occur. It's going to be a stenotic event that occurs in one of the intracerebral penetrating vessels that either arise from the middle cerebral artery stem, the basilar or vertebral artery, or the circle of Willis. And those are all terms you've already heard me say when I described to you basically the gross circulation of blood in the CNS. So this is where you're going to see more of your transient events, but infarction can also occur as a result of these lacunar or lacunar, depending on how I want to say it, small penetrating vessel events. So with low flow ischemia, usually it lasts a short time, so it's just a few minutes, and it's often recurrent, so it happens more than one time for a few minutes and then it goes away. So for example, they may have dysarticula where they're unable to speak, they're having difficulty forming words, and then all of a sudden they'll be able to do it and it will freak them out and they'll say, oh my gosh, I don't know what's going on, something's wrong with my speech. And then, hopefully they have a loved one that is saying, okay, definitely get this patient to, get this person to the ED right away, call 911. Typically it occurs once per week or up to several times a day even with a low flow ischemic process. So again, this can be something that it lasts a short time, but it can be significantly recurrent as well. And hang on, my little schnauzer Millie wants me to hold her, so she's going to... Okay, sweetheart. Okay. Also, by lesion location, we can look at the clinical presentation as well. So the origin of the internal carotid artery at the siphon portion of the ICA, where collateral flow into the circle of Willis is inadequate, or in that MCA stem. And what you're going to see in ischemia that is a consequence of one of those areas are hand, arm, leg, face, tongue, or cheek numbness. Again, you're going to find these things in, for example, assessment of cranial nerves 5 and 7. Recurrent aphasia syndromes, where you get ischemia in the dominant hemisphere. And you can also get recurrent neglect of the non-dominant hemisphere ischemia as well. So they get this recurrent neglect syndrome where they typically neglect the side of the infarct, and it's actually, you got to remember, it's contralateral, so it's the opposite. So if they've had a left-sided infarct or a right-sided infarct, they might they might neglect the left side if it's on the right, or the right if it's on the left. Now, that's, to me, that's kind of an old school way of looking at it, because we've now learned to look at stroke a little bit differently, and we can look at the tissue a little bit more specifically. So this neglect, recurrent neglect, really is, I think it's more of an old school thought, but it is still in the literature. Vertebral basilar junction, or the basilar artery, you're going to see things like dizziness with or without spinning, or vertigo. Remember that dizziness is I'm spinning, and vertigo is everything around me is spinning. So that's one of the ways that to differentiate between dizziness and vertigo. You may have numbness of one side of the body or face, dysarthria, or diplopia, all occurring if you've got an occlusion here in the vertebrobasilar junction or the basilar artery. And then proximal to the mid-basilar artery in the pons area, you're more likely to have bilateral leg and arm weakness, numbness, a feeling of heaviness in an arm, dizziness, a feeling as though all energy has been drained, and they may say that they have this impending feeling of doom. So these are all important things to recognize in acute presentation for brain ischemia. And I've already gone over some of this when we looked at the diagrams just a minute ago, but this is basically a review of that, and some people learn a little bit better by seeing it on a slide rather than looking at it in a picture. Top of the basilar artery or proximal posterior cerebral artery, all of the recurrent symptoms, overwhelming drowsiness, vertical diplopia, eyelid drooping or ptosis or an inability to look up, and transient ischemia at the top of the basilar artery is usually due to an embolism rather than a low flow event. So you're more likely to see an embolism type of issue occurring at the basilar artery, at the top of the basilar artery, than you are, for example, an atherosclerosis type of occurrence. Embolic event, it typically lasts hours. It may be infrequent and result from an emboli of a specific source like I mentioned just a minute ago. They are subject to natural thrombolysis and migration, and they'll typically break off of a fresh thrombus. One of the other things that you can see this is, for example, septic emboli. If a patient gets, for example, vegetation that grows on one of the vessels from endocarditis, then that vegetation can actually break off, form a septic emboli, and lodge into the brain tissue as well. So that's another cause of emboli. Symptoms depend on the size of the embolism in relation to the size of the artery that's occluded, but this is still an ischemic event. It's just a little bit different in terms, actually it's a lot different in terms of its pathophysiology, right? Okay. So looking at ischemic events that result from emboli, we can break it down to anterior cerebral circulation, where we can look at the MCA. We'll see contralateral hemiplegia, aphasic syndromes in the dominant hemisphere, anagnosia or neglect in the non-dominant hemisphere. In the MCA branches, you're going to have more focal symptoms such as hand alone or arm or hand numbness, weakness or heaviness, and it may be even as specific as they're going to tell you, well, my thumb has gone numb, or I feel like my hand is swollen, or my hand is numb. It can be a real specific focal symptom when the MCA branches get occluded by emboli. In the carotid region, you're going to see more transient unilateral visual disturbances, usually due to an arthrothrombotic disease in the internal carotid, and you need to consider carotid dissection and embolism from the aorta, heart, or an unknown source when you get this carotid type of symptomology as well. Like I mentioned before, you want to look at where the cause is, and so here in the carotid region, think about the circulation that's involved in that, and particularly the cardiovascular or the cardiac circulation that's right below it. You're likely to see that embolism move into the carotid vessel and cause that kind of damage. Posterior cerebral circulation, so you see this in the vertebrobasilar posterior cerebral artery territories. You're going to get things like transient ataxia, dizziness, diplopia, dysarthria, quadranatinopsia. I don't even know what the hell that is. We'll have to look that one up. Hemianopsia, I'm guessing it's separation of the visual field into 4 quadrants. Hemianopsia, numbness, cross-face and body numbness, and focal hearing loss. Okay, let's take a break for a second. I want you to look at something. Posterior cerebral circulation. Take your hand right now and go along the trapezius muscles in your neck. I want you to reach out and do this with me. That basically, underneath all that musculature, is where your posterior vertebral arteries are. So, follow that up. Where are you now? You should be touching the occipital region of your brain or of your skull. So, what is located in the occipital region? Well, the cerebellum. Look at the first thing I've got listed here, ataxia. What else is located in the occipital region? Your visual cortex. Hemianopsia, right? Hemianopsia is here. This quadra-whatever-opsia is here, right? All of these things you should be thinking about in terms of a posterior infarct. We already talked about the top of the basilar artery, that being more likely to be an embolic event, sudden overwhelming stupor or even coma, and then the distal branches of the PCA, homogeneous field defect or in memory loss is what you see. So again, these visual changes, these ataxic events, more likely to occur in a posterior occlusion than an anterior occlusion. But really, and you're going to see this on your exam. I'm going to give you symptoms. I'm going to say, where do you think the occlusion is located? And I'm only doing that because your board exam thinks that's fair game territory. So I want you to know it. But in reality, I want you to think about the fact that in a clinical presentation, your posterior occlusions are going to occlude the functions of the cerebellum and the visual cortex region, and that's going to result in things like gait, balance disorders, ataxia, visual disturbances, those types of things. So that's kind of the takeaway from here. Lacunar or small vessel ischemia, embolism are rarely the cause of these types of injuries. It's similar to lacunar strokes, face, arm, and leg weakness or numbness. It's brief and repetitive. Serious disease in the parent vessel must be excluded before a lacunar or small vessel ischemia can be definitely diagnosed. Lacunar ischemia may precede infarcts, and these infarcts occur in a stepwise or progressive fashion where you get a pattern called lacunar syndrome, which suggests a small vessel etiology. I have seen this presentation a handful of times on CT, where the patient has an acute event, and you get a CT scan, and the CT scan shows chronic lacunar changes or chronic lacunar ischemia, those types of findings where it's in the smaller vessels of the brain, and you're more likely to get this face, arm, and leg weakness or numbness type of symptomology. How do we manage stroke? So that's important. So we talked about assessment, we talked about the physiologic properties of stroke and what's the difference between ischemic stroke and hemorrhagic stroke and the three main pathophysiologic processes that are involved in ischemic strokes. But how do we manage these things? That's important. Obviously, we have to know how to do a proper assessment. We talked about that. But even more importantly, how do I respond to it? So we've already gone through the data. We know tons of people are affected by this every year. 140,000 deaths in the United States annually as a result of stroke. It's a true medical emergency. We already knew that. What is the goal? The goal is salvage of the ischemic penumbra. Okay? Save the brain tissue. That is the goal. In 1995, the National Institute of Neurological Disorders and Stroke, the NINDS, demonstrated improved outcomes with IV recombinant tissue plasminogen activator, or TPA. It's the only treatment approved by the by the NINDS and by other authorities for treatment of AIS when they present within 3 hours of symptom onset. Now, there's some caveat to that. We're going to move in just a second to where that time can be extended for certain populations. But for right now, let's focus just on this 3 hour of symptom onset. So this intervention has truly been life-saving. It has been a complete change in the game of how we manage stroke. The problem is we've got to get people into treatment immediately. We cannot let them blow off symptoms, excuse symptoms, not consider symptoms, and not get into care. Time is tissue. Very important takeaway. What are the risk factors for stroke? Talked about some of these, and I told you I was going to get on these a little bit further as we moved into the lecture. Heart disease, hypertension, prior myocardial infarction, severe atherosclerosis, diabetes. Diabetes just by itself doubles the risk of having a stroke. Sugar damages the blood vessels. Sugar strips the tunica intima. It inflames the tunica intima significantly. It is a major risk factor for stroke. Hyperlipidemia, same pathophysiologic process. I don't have any evidence of this. I'm going to go out on a limb and say this. My guess is, in your clinical career, you are going to see hyperglycemia and diabetes replace hyperlipidemia as the number one identified risk factor for cardiovascular disease and for stroke. I don't know. I might be wrong. I don't think I am. I think what we're going to be seeing in the future is the amount of vascular damage that occurs as a result of hyperglycemia is even worse than hyperlipidemia. I would bet money on it if I were you. I could be wrong. Who knows? I'm totally just saying this based on my own experience reading the literature and getting some more experience in this area. But I would not be surprised if you saw hyperlipidemia be replaced with hyperglycemia as a major risk factor in the future, as the most important, if you will. Obviously, if the patient's already had an MI, then we already know they have that damage. Older people are more likely to have ischemic and embolic and thrombotic types. Like I mentioned before, they're more likely to get the damage to the vessel that occurs over time versus your younger person more likely to get, for example, an embolism from an AFib event or a hemorrhagic type of stroke, either from being stupid and snorting stimulants and doing things like that, or just from AVMs that rupture or other things that occur in younger folks. Hypertensive transient ischemic events are more common in blacks and Asians. Blacks, Asians, and women have a lower incidence of occlusive disease of the extracranial carotid and vertebral arteries than white men. But overall speaking, in terms of morbidity, blacks and men are at more risk than whites and women. But I mean, yeah, that's an important thing to know in terms of risk factors and knowledge of health disparity. But, you know, again, it doesn't matter what color skin or what background the patient is when they present. I've seen some of the worst cases of stroke that I've ever seen in a female patient that presented one time when I was an emergency room nurse. I will never forget when she came in, both of her pupils were blown. She was in her late 40s. She could not talk. She couldn't communicate. And she was having a massive stroke, and it was almost like she had locked-in syndrome, where she was, you know, she couldn't communicate, she couldn't even, she tried to blink her eye. I remember that. I mean, it was just a horrific, thing for me to see. And I was a very young nurse. I was only 22 years old when I graduated with my BSN and as a nurse. And so for a 22-year-old to be working in the emergency department managing a patient like that, I remember it being, very shocking. One of the things I'll say about working in the emergency room is it makes you grow up pretty fast, because you see a lot of things. For a 22-year-old, looking back on the 2 years that I spent in the emergency room as a nurse, not only did I learn a ton, but man, oh man, did I see some really crazy, interesting things. There are also demographic and historical risk factors that we can continue on here. Small vessel strokes, strokes of undetermined origin, and large vessel strokes are going to be more common among blacks compared with whites. Hypertension, the most common and most important stroke risk factor. Screen your patients for hypertension. Treat them. We are really bad about this in the hospital. Patient presents with hypertension. Who cares? That's a primary care problem. We treat them for whatever they're in the hospital for. We treat them even though they still have 170 systolic pressure, and then they go up and a few years later, or they go home and a few years later they stroke out. Well, that's partly our fault. We've got to have proper follow-up for these people when they're hypertensive. Smoking is also a major risk factor. It will increase the likelihood of stroke by 2, just like diabetes. Increases the risk of extracranial occlusive vascular disease. It obviously accentuates vascular damage. Very disgusting, very unacceptable. I don't even like to call it a habit. I call it a lifestyle choice at that point, because there's just no excuse for smoking in modern times, in my opinion. There's just no excuse for that behavior. No offense to anyone out there that might be a smoker, but I'm sorry. Vaping is no better. Vaping carries an extensive amount of nicotine. Some studies have shown it's 2-3 times the amount that's in a cigarette. So I get sick to my stomach when I see ads on TV trying to market vaping as a safer alternative to cigarette smoking. That's ridiculous. And even marijuana smoke. People think marijuana is a safe alternative. No, it's not. The same carcinogenic, inflammatory properties that occur from inhaled cigarette smoke occur when you inhale marijuana. So there is no difference. Anyway, get off my soapbox. Alcohol. More than 1 alcoholic drink per day for women and more than 2 alcoholic drinks for men increases the risk of stroke significantly. And then binge drinking. And I want to say binge drinking is defined by drinking more than, I think it's 3 or maybe 4 drinks in a setting for everybody. Look that up though. I don't know off the top of my head the exact definition of binge drinking, but I want to say it's more than 3 in like one setting or something like that. Your classic stroke symptoms. They often develop suddenly and temporarily improve, or they slowly worsen, depending on the type of stroke and the area of the brain that is affected. Teach your patients the FAST acronym. This is very important. So when we look at the acronym, first is the face. Sudden weakness of the face, blurred, doubled, or decreased vision. A is the arm, sudden weakness or numbness of one or both arms. Speech, difficulty speaking, slurred speech, garbled speech. And then time. Time is of the essence in stroke treatment. We talked about this already. Time is tissue. The sooner treatment begins, the better chances are for recovery. And this is you may have seen this in the hospital, you may have seen this planted everywhere in medical institutions. We want our patients to see this. We want them to learn fast. You better know it for your exam. The chain of survival. I don't know where I got this from. I may have gotten it from an old lecture that I had when I was in school, but I left this in because I think it's important. Look at all the D's. The chain of survival. Detection. The patient or bystander recognizes the signs and symptoms. Dispatch. We call 911, get them on EMS. Delivery. Prompt triage and transport to the most appropriate stroke hospital and pre-hospital notification. Door. Immediate ED triage to a high acuity area. Prompt ED evaluation, so data collection, stroke team activation, lab studies, and brain imaging. Decision, diagnosis and determination of the most appropriate therapy, discussion with the patient and family. Drug, administer of the TPA or whatever agent, whatever intervention we're going to be doing. And then disposition, timely admission to the stroke unit, the ICU, or a transfer. All right, so now you're going to start noticing some additional slide material that I've brought in from the AHA and the ASA. I thought instead of giving you my paraphrased lecture, I would get the lecture directly from the American Heart Association and the American Stroke Association, which I did, and I was able to get permission to use them for this lecture. So let's talk first about pre-hospital stroke management and systems of care. We have improved outcome data that show those outcomes result when you have an increased awareness of stroke signs and symptoms, maximization and utilization of EMS, optimized pre-hospital management and triage, establishment and continually improved quality of care at stroke centers, and rapid transport across hospitals when necessary. Let's look at this EMS system. So EMS systems, I know we're not in charge of EMS systems, but who knows, maybe one of you someday will get into management and this might be something you want to look at. First of all, EMS needs to be using validated stroke screening tools. They need to identify regional hospitals that can give IV alteplase and those that can perform thrombectomy procedures. Where do we need to go if I've recognized that my patient is having an acute stroke? Who is the best acute stroke facility? The AHA mission is Lifeline has proposed a severity-based triage algorithm. You can see it there on the right. I won't test you on it, but read it for your own knowledge. Uncertainty exists over optimal algorithm for optimal pre-hospital screening. Customization of proposed algorithm to account for local factors is also needed. Obviously, if I've got a patient that is in a rural setting, for example, I've got to get him to the closest hospital. I don't have the luxury of driving an extra hour and a half to get him to a stroke center. So those are things that would be an example of that. We have certifications that are available for stroke centers. You can see them here. And then there are also tiers of stroke hospitals that are proposed for either acute stroke ready hospitals, primary stroke centers, and then comprehensive stroke centers. So identifying which of the hospitals in your area are which one of these criteria or meet the criteria for these classifications would be important. A stroke center should have an organized protocol for emergent evaluation of suspected stroke. They should have a designated acute stroke team, and among patients that receive IV alteplase, our primary goal is door to needle, less than 60 minutes, or 60% or less, I should say, in more than 50% of our cases. And a secondary goal of door-to-needle time of 45 minutes or less in the remaining cases. So really, the goal is door-to-needle in 60 minutes or less. Okay, so that's very important. Telemedicine. I wanted to include this because you're seeing telemedicine as an emerging area of treatment. Teleradiology is shown to be useful for rapid imaging interpretation. To be honest with you, that's pretty much what all of radiologic reading is now. There's very few dedicated radiologists that are housed inside hospitals anymore. Most of them are either working from satellite offices or working from even home and looking at images on their own computers at home and doing all that type of stuff and being, doing obviously in a stroke case a more rapid interpretation. Telestroke can be effective for IV alteplase decision making. Meta-analysis comparing telestroke to stroke center showed no difference in mortality or functional outcomes at 3 months. Telestroke may be reasonable for triaging patients for mechanical thrombectomy as well. There was only one single observational study that looked at this, but it showed similar rates of reperfusion and functional outcomes between telestroke patients and those admitted directly to a tertiary care center. Okay. Organization and integration of components. Stroke systems must integrate IV alteplase capable and mechanical thrombectomy capable centers. Thrombectomy requires patients to be in an experienced center. We're going to talk more about this in just a minute. Non-invasive vascular imaging can select patients for transfer to a thrombectomy capable center. Decisions around developing this capability require a realistic expectation that accounts for local resource availability, and guidelines and protocols must ensure a rapid transfer that's available 24/7. Okay, moving to emergency evaluation. Stroke scales. These are standardized severity scales that quantify the amount of neurologic deficit that your patient is experiencing. The good thing about these is they're universally applicable, so they can help facilitate communication, they can identify patients for acute treatments, and you can also monitor for improvement or worsening. So if the scale worsens, for example, between the time the patient's been in the ED and got their alteplase and then they've arrived in the ICU and they're not neurologically improving, but in fact neurologically declining, that can be an indication of a serious adverse event associated with the alteplase therapy, and we'll talk more about that in just a few minutes. The National Institute of Health Stroke Scale is a great scale to use. It's rapid, it's accurate, it's reliable, it can be performed by a broad spectrum of providers, nurses included, bedside nurses can use this. It really truly is the preferred scale. I think I've got a picture of it somewhere. Well, we'll get to it. If it's not in this lecture, it's in one of your other lectures. I've got an actual picture of that. Okay, let's look at this. I thought this was an important thing to look at as well. There are also clinical situations that can mimic a stroke. So let's look at these. The first is psychogenic. You have a lack of objective cranial nerve findings. Like I mentioned before, you're going to do your 12 cranial nerve assessment. If there are no focal deficits and the patient is able to successfully perform all 12 cranial nerves, they are neuromuscularly intact with 5 out of 5 upper and lower extremity strength in every single test that you do, this is probably not a stroke then, okay? Something else is going on. Non-vascular distribution of neurologic findings and a very inconsistent exam. This could be psychogenic. Seizure disorder. Do they have a history of seizure, or was there a witness seizure activity or postictal period? Hypoglycemia. Do they have a history of diabetes, insulin use, insulin misuse, a low serum glucose, decreased level of consciousness? Obviously, when a patient presents with altered mental status, the very first thing that we're going to do is what? If you just said check blood sugar, you're wrong. The very first thing you're going to do is check oxygenation status. Remember, airway, breathing, circulation. What is their pulse ox? Are they perfusing enough, right? Are they oxygenating? The second thing we're doing is we are checking for hypoglycemia. Is this a case of hypoglycemia? That can result in decreased level of consciousness. That can be what looks like a stroke, but is really not a stroke. Migraine with aura. I may have told you this story in another lecture, but yours truly had this happen to me. I think I was around 27 years old. I started having significant weakness on the left side of my body. It was either the left or the right. I don't remember. It could have been the right. I was having visual field disturbance. I had this dysarticula. I was unable to talk. I was having significantly slurred and slowed speech. It was the absolute scariest hellish moment I've ever gone through, I think, in my life. I tripped going up the stairs because I had ataxia, and I called my good friend, who I'm still good friends with, my former graduate assistant, Kathy, who is now a nurse practitioner in not upstate, but Long Island, New York. And I called her and I said, I'll never forget, I said, Kathy, something wrong with me. I swear to you guys, I know you're probably laughing because I sound stupid, but that is exactly what I sounded like. And just saying that and talking like that was enough to scare the living you know what out of me. And thank God I had Kathy. And Kathy said, Chris, oh my God, I think you're having a stroke. She probably should have called 911. I probably should have called 911, but I was in complete denial. I didn't even want to go to the hospital. That's how stupid I was. And she came and got me, took me to the hospital. By the time I got to the hospital, my focal problems had pretty much disappeared. That was followed by the absolute worst headache of my life, photophobia, phonophobia, you name it. And I spent a day and a half in the hospital, got a complete neurologic workup. Everything was negative, thank you, Jesus. But it was chalked up to this atypical migraine, a complicated migraine. And so by the way, that was a $33,000 hospital bill that I had to pay. You know, my copay on it was $3,000, but $33,000 for a complete neuro workup for 1 day and a half in the hospital. Hypertensive encephalopathy, headache, delirium, significant hypertension, cortical blindness, cerebral edema, and seizure. Wernicke's encephalopathy or Wernicke's-Korsakoff syndrome. You've probably heard of that. Usually, there's a history of ETOH. Abuse, ataxia, ophthalmoplegia, confusion, CNS abscesses, histories of drug abuse, endocarditis, medical device implant with fever, CNS tumors can cause this as well, and then drug toxicities. And these are just some 3 examples, like lithium, which we don't really use a whole lot of anymore, but you might see that in bipolar management, Dilantin and Tegretol, which are used for management of seizure disorder. Okay. The ABCs of stroke evaluation are very important. Airway, breathing, circulation, obviously, neurologic deficits and possible comorbidities. Most important question you can ask when getting your history: when was the patient last symptom free? If they're not able to tell you that, then when was the last awake and symptom free, or when were they last known to be normal? Very important, probably the most important question you can ask, because that is going to provide to you the time measurement that you're going to need to start the clock. Are they eligible for alteplase therapy at this point? Well, the only way to know that is to know when the last time they were symptom-free was. Preceded by similar symptoms that resolved. If so, then the therapeutic clock is reset. That's an important concept. It's not when the very first symptom occurred, but when the last symptom occurred. So if they are having this low flow pathophysiologic event like I described to you earlier in the lecture, and they're having these recurrent symptoms where they're getting better, and then they're having lucidity, or there's no symptoms, and then all of a sudden it happens again in 20 minutes, well then that subsequent 20-minute time period is where the clock starts. So it resets, okay? So that's important. Risk factors. Do they have known risk factors for atherosclerosis and cardiac disease? Are they abusing drugs, particularly stimulants, which are known to cause vascular damage? Do they have a history of migraine, seizure, infection, trauma, pregnancy, anything else that might be related to their presentation? And then the algorithm for initial AIS evaluation is identical. Regardless of the location, if it's in the field or the ER, already admitted to the ICU or other area, we use the same assessment algorithm. We don't change it. The initial stroke physical exam, we're going to start this after we've looked at vital signs, after we've looked at SpO2, and really I could add to that after we've gotten blood glucose. But really, in reality, we're doing all of this together because we're going to use an interdisciplinary approach to all this, where we're going to have respiratory therapy hooking the patient up to oxygen, maybe getting an ABG depending on the presentation. Nursing staff is dropping an IV line. They're getting glucose testing, all of that stuff going. We've already got our vitals. Maybe EMS even gave us those. Focus to identify other potential causes, coexisting comorbidities, and other issues that will impact the care. Looking at the head and face, signs of trauma or seizure activity. Listening in the carotid region for bruits. If there is a bruit present, then you know there's probably a greater than 75% or even higher occlusion. Chest, signs of CHF, murmurs, dysrhythmia, crackles. Skin, stigmata of coagulopathies, platelet disorders, trauma, embolic lesions that might be present. And this is a brief but thorough assessment that we're performing. So very, very important concepts here. Okay, good. I knew I had it in here somewhere. So this is the NIH stroke scale. So at this time in the lecture, please pause the video, take a look at the NIH stroke scale. I think you'll find it to be pretty interesting. Really good information here in terms of numerically assessing the patient. It's a lot more valuable than, for example, the GCS or another type of scale that doesn't provide the specificity that this scale would provide. Okay, so it's an initial evaluation stroke scale is standardized, quantifies the degree of deficit, facilitates communication. We've already talked about all this. Okay. Access to neuro expertise. This really depends on local resources. In the Central Florida region, we're lucky. We have large medical centers here. Almost all of our major hospitals are stroke centers. They're identified stroke centers, so it's not an issue to get access to neuro expertise. Remember that a main differentiator between a level 1 trauma unit and a level 2 trauma unit, or even below that, is going to be availability of neurosurgery in the building who can respond to a neurologic emergency, including stroke. Identifying stroke in the emergency department there's limited evidence for this in the ERMD, and there's an ongoing study by the NIH on assessment and safety of TPA use in community ED settings. I'm not sure what I meant by this limited evidence for ERMD. I don't know what that means. Multiple methods of support, local physicians, telemedicine, which we've already talked about, and inefficient use of local and regional efficient use of local and regional resources. All these things important in terms to access to neuro expertise. We already talked about kind of how we categorize these things. Stroke is the same classification that we would use for a transient ischemia. So it's either going to be large artery atherosclerotic event, small vessel occlusion like a lacunar, cardioembolism, other etiology, or even undetermined. And your emergent diagnosis, the gold standard is going to be a CT scan without contrast or an MRI. But again, the gold standard is going to be your CT scan without contrast. Okay, I think this is a really good table because it's information we've already presented, but it kind of presents it more globally. So when you go back to study stroke and you're studying for your exam, you might want to start with this subtype scale where it talks about ICH, subarachnoid, ischemic, thrombotic versus ischemic embolic, and really compare these. Know these. I don't think I'm going to get that explicit on your exam where I would ask you to identify the difference between a thrombotic and an embolic, for example. But this is important stuff to know. So take a look at this chart. I think it'll be good for studying, and then go back and look at the other slides that we already presented in terms of the data that are on there. So imaging is crucial. It can differentiate between an ischemic type stroke versus a hemorrhagic stroke prior to deciding on thrombolytic administration. Obviously, we are not going to give a patient alteplase if the patient's having a hemorrhagic stroke. That makes no sense whatsoever, right? So that's why it's so important to rapidly get a CT scan without contrast so that we can make a quick decision. What was our NIH, I'm sorry, not NIH, our AHA, ASA guideline for door to needle? Hopefully you remembered 60 minutes, okay? That's going to mean we get that patient from door to CT room in 20 minutes. That's the gold standard, 20 minutes. Get them in, get them imaged, make a decision. Most stroke centers, the time from symptom onset is a major factor determining if the candidate for IV thrombolysis, which is up to 3 hours, or intra-arterial therapy, which can be up to 6 hours, is going to be an option. An emerging concept that we're seeing is perhaps physiology rather than time should be the determinant. So some may have salvageable brain tissue or salvageable penumbra despite time after the 3-hour interval. I'll talk more about that in just a minute. Physiologic estimates of tissue viability are preferred, and so a CT and an MRI have the potential to provide some of that measurement. So imaging is crucial. MRI is wonderful if you have the potential to do it. Otherwise, the gold standard is going to be a CT scan without contrast. Here's some more information about brain imaging directly from AAHA and ASA guidelines. Urgent brain imaging is required. The benefit of IV alteplase and thrombectomy are time dependent. So reducing time from arrival to imaging, like I said, our goal is less than 20 minutes from ED arrival, can improve our door to needle time, which we already said the goal was less than 60 minutes. Non-contrast CT is adequate. The primary goal is to exclude ICH, just like I mentioned previously. Routine MRI, it's wonderful to have. It's not cost effective. It doesn't significantly change your treatment course, and there are inadequate data to establish who even requires it. So MRI is wonderful, but do the MRI after you've done the CT scan without contrast, have initiated therapy, and the patient's been hospitalized and stabilized. Then you can worry about getting an MRI in the ICU or wherever they are. There's insufficient evidence to withhold treatment with alteplase based on a hypodensity that might appear on the non-contrast CT. There's no interaction between non-contrast CT hypodensity and functional outcomes in an RCT pooled analysis. So you should not withhold alteplase therapy based on a hypodensity or even a hyperdensity, particularly what we call an MCA sign. Routine use of MRI to exclude cerebral microbleeds is also not recommended, okay? So what's the takeaway from this? Don't worry about a hypodensity or a hyperdensity. That is not going to be something that is going to stop the patient from getting alteplase. Advanced imaging, vascular and perfusion imaging should not delay alteplase treatment. Use of imaging to select AIS cases for alteplase treatment with uncertain symptom duration is also not recommended. And for patients who meet criteria for endovascular treatment, it is reasonable to provide these people with a CTA, so an angiography. So in all honesty, I've never seen that done. You're just too worried about time, and you're too worried about getting the patient treated. And so CTA is really not going to be what you're going to get as the gold standard. It's going to be CT without contrast. But I suppose if you're working in a level 1 trauma, and you've got a neurosurgeon on board that says, I looked at this CT, I think this patient is going to be a candidate for an endovascular intervention, then he or she might order a CT angiography or a CTA and make some decisions based on that. But the gold standard for you is a CT scan without contrast. Advanced imaging can occur for thrombectomy 6 to 24 hours from the last normal. Two recent RCTs that I thought were important include CT perfusion or an MRI perfusion to select patients with salvageable brain tissue despite prolonged time from the last normal. So this is what I was talking about before, where it might actually be longer than 3 hours. Randomized to thrombectomy versus no thrombectomy, both trials showed large benefit from thrombectomy procedure. So typically you have looked at this at like 6 hours, where they're a candidate for some type of endovascular procedure, like a thrombectomy, for example. But some of the newer guidelines, this 2018, the newest guideline that we have, shows that once they get more advanced imaging, then all the way up to 24 hours, they might actually benefit from thrombectomy. So again, that 6-hour cutoff may change depending on what imaging studies are showing. So like I said a million times already, the non-contrast head CT is the initial image of choice. Pretty much all of the area hospitals here have that capability. I don't know of any that don't. Ability to exclude an ICH can demonstrate subtle signs of early edema or infarct. Early changes of ischemic can also occur within a few hours, so you can have reduced attenuation in the basal ganglia show up on a non-contrast head CT, loss of gray-white differentiation in the insular region, low density in the cortex and subcortical white matter, and loss of sulcal markings, which can all indicate, thrombotic type of disorder. This is what the basal ganglia look like on a CT, and this is what you're seeing here in terms of the structures that are located here and here. So pretty cool when you see what that looks like on a CT scan. The insular cortex and the basal ganglia are going to be located here. Okay, so you can see what these look like in the red region here, and you can see some abnormalities, I believe, in this particular image as well. So what imaging changes are you going to see in a CTA? Well, spiral cut CTs will show intracranial and extracranial circulation. Obviously, it requires a contrast material, contrast dye. So if the patient has renal failure or they have an allergic hypersensitivity, you're not going to be able to do this. The other thing that's important when you're getting a CTA is you want to include the neck, and you want to also include the aortic arch. Why? Anteriorly, that's going to tell you your flow in your carotids. Posteriorly, it's going to tell you the flow in your posterior vertebral arteries, and it's also going to help you rule out dissection of the aortic arch. When you get a dissection, that can actually cause lack of cerebral perfusion and can be it's not a true ischemic stroke, but it can certainly mimic that and cause symptoms that are indicative of immediate need for surgery. CT perfusion scan can look at cerebral blood flow and blood volume. A helical scanner with IV contrast can show you construct time-dependent concentration curves of the contrast, and you can calculate a mean transit time and calculate cerebral blood flow from that. And that's correlated with a final infarct size and outcome. And this is where you can see in couple of different images I pulled here. Let me get my arrow out. There we go. So A is normal. This is a normal CT scan of the brain. This is 2 hours after a patient presented with aphasia and left hemiparesis. B is a repeat CT scan 5 hours after stroke onset and shows some early CT changes, including basal ganglia hypodensity, loss of the insular ribbon, okay, and some slight effacement of the sulci on the left. In C, you're getting 5 hours of CTA, so it's 5 hours after stroke, showing a complete occlusion of the left middle cerebral artery. And in D, you're getting rapid reconstruction of the CTA, again showing occlusion of the left middle cerebral artery. So pretty cool diagnostic imaging that I thought you would appreciate on a CT without contrast versus a CT with contrast at start of stroke onset, 2 hours post, and then 5 hours post. This is a brain perfusion mapping. It's pretty cool. A is showing you cerebral blood volume with no clear evidence of a core infarct. B is showing you cerebral blood flow with a decrease in the right middle cerebral artery. And C is showing that the mean transit time has a delayed perfusion in the right MCA. You can see that over here, in the right MCA territory. These sequences taken together indicate a large ischemic penumbra in the right MCA territory. So look at the differences that you're seeing here in the perfusion uptake in all three of these films, right? Pretty interesting. The xenon CT. This is a quantitative measure of blood flow as opposed to the qualitative that we just saw. The patient will inhale an inert gas, and the outcome of a xenon CT is highly correlated to the area of infarct, but not the amount of ischemic penumbra. It suggests that after the first few hours, the size of the core infarct, not the amount of penumbral tissue, may be the most important imaging parameter that determines the suitability for therapy. And this is what a xenon CT looks like. If you've ever seen a VQ scan, it looks similar to that. I will say it does look similar to our perfusion scan, which is what you saw here. Except here, to me, it's not quite as, I don't know, pretty looking. But this comes from a xenon CT blood flow study from a patient with a large left hemispheric stroke, which this was taken 3 hours after the onset of symptoms. And if you look closely, you'll see, for example, oh shoot, sorry. If you go, oh crap, what happened? Okay, if you look here, you can see where this perfusion deficit is occurring. It's really scary when you look at this third image here and see that this left area of the brain is essentially non-perfused. So you have to think that this is a large vessel type of injury that's taking place here that is resulting in the smaller vessels of that hemisphere not being able to feed the brain tissue. And it turns out it's a middle cerebral artery occlusion. MRI compared to the CT, it's more sensitive, especially in the brainstem and the deep white matter areas of the brain. The MRI stroke protocol, you will see a diffusion coefficient used to evaluate acute ischemia. You can see multiplanar gradient recalled or gradient recalled echo or GRE. Those are used to evaluate for hemorrhagic events. A flare, which evaluates hyperacute and acute stages of stroke, and then perfusion weighted imaging is often used as well. I've never worked personally in a level 1 trauma facility, so I've never worked side by side with a neurosurgeon or a neurologist in the workup of acute of acute stroke. I've only worked with an ED physician during this, so I've never seen these advanced type of imaging studies done on the initial presentation. This is something that you would most of the time see done after the patient's been stabilized, admitted into the ICU, and worked up for further evaluation. So this is an MRI. The A image here that you see shows a right basal ganglia stroke. This is a diffusion weighted scan, I believe. And then in B, you'll actually see a perfusion weighted image, which shows this enhanced mean time to enhancement. You can see that occurring here in the red. And you can see that when you take these things together, you get a suggestion of a large ischemic penumbra in the right MCA. Okay, so again, really significant amount of injury that's taking place here on both of these MRI images. MRA. So this is like an MRI, but it uses angiography. The patient takes a gadolinium contrast. I had to get one myself when I had that event that I told you about. It will detect things like dissection or occlusion in the circle of Willis, or disorders of the extracranial vertebral and carotid arteries, but it does not detect the small peripheral branch arteries. So it will not show you lacuna-related injuries, for example. Differentiation between severe stenosis and occlusion is unreliable with an MRI. Apparent occlusions by MRA should be confirmed with angiography as well. All right, moving back to our most recent guidelines, other diagnostic tests. It's critical not to delay IV alteplase. In ischemic stroke, we've got to get the TPA on board. The only assessment that can precede this is going to be glucose. Baseline EKG and troponins are recommended, but again, if that is going to delay IV alteplase therapy, we don't do it. Utility of the chest x-ray is uncertain. There's been a cohort study that's compared patients that both got a chest x-ray and those that didn't, and it showed a longer door to needle time in those that got the chest x-ray, and there was no difference in cardiopulmonary events. So again, chest x-ray might be important, but something that is not going to be something you're going to do in terms of right-away therapy. Mom, I'm recording a lecture. I'll have to call you tomorrow, okay? I love you. I'm okay. I'm sorry I couldn't call you earlier. I've been recording lectures. Okay. Okay, Mom. Sleep tight. Good night. Love you. I'm fine. I love you. Bye-bye. Sorry about that, guys. I had to put you on pause for a minute because my mom was calling to tell me good night. Incidentally, it's 1 o'clock in the morning here, so she was worried because I usually call her late. Not that you care. Okay, other lab tests. Diagnostics, suspicion for blood disorders as a potential source. I kind of mentioned this. Cryptogenic stroke, where the origin is unknown, that might be helpful. If they're 45 or younger, they have a history of coagulopathy, multiple venous and arterial occlusions, suspected or confirmed cancer. Remember that cancer heightens coagulopathy, cancer heightens inflammatory processes, so this might be something that you would suspect in someone that was, had a history of CA. And then a family history of thrombotic events all are going to be significant for this. Cardiac testing, consider a cardiac source if it's an embolic ischemic event happening. 12-lead EKG, you might pick up, for example, you probably will pick up, hopefully pick up AFib. Echo if they've got, if they're a candidate for anticoagulation or if you suspect endocarditis. Transthoracic echocardiography or TTE or TEE, transesophageal. The TTE is non-invasive, better to estimate left ventricular function and detect apical left ventricular thrombi and mitral annular calcifications. The TEE is the test of choice for aortic atherosclerosis evaluation, better to detect left atrial thrombi, intra-atrial septal abnormalities, and visualization of the left atrial appendage, which can be a main site of thrombus formation. Back to our guidelines. So now we're into supportive care, and emergency treatment. Look at this. Airway support and ventilatory assistance are recommended for the treatment of patients with acute stroke who have decreased consciousness or who may have bulbar dysfunction that would cause compromise of the airway. Supplemental O2 should be provided with our goal to keep the SpO2 greater than 94%. Supplemental oxygen, interesting enough, not recommended in non-hypoxic patients. Used to be, patient came in, they were having stroke-like symptoms, even if they were satting at 100%, we still put them on oxygen, thinking, well, hyperoxygenation will be beneficial for them. No, the data do not support that. Hyperbaric oxygen is not recommended for patients with acute ischemic stroke except when caused by air emboli. Blood pressure. Ideal observation of blood pressure remains unknown. We only have observational studies, so we don't really have an ideal blood pressure. I'm going to give you some guidelines here in a second. There's no clear data on fluid choice, volume, or duration. You've heard me say time and time again that really the fluid choice for fluid resuscitation in an intact functioning liver patient should be lactated ringers, but rarely is that done, even though the guidelines tell us that. Blood pressure with IV alteplase. You want to keep the pressure less than 185 over 110 prior to administration and less than 180 over 105 for 24 hours after administration. Target based in blood pressure for RCTs of IV alteplase, some data suggest hemorrhage risk is higher in patients who have higher blood pressure, or if they have a lot of variability in their blood pressure, but exact blood pressure measurement that actually increases that risk is really not known. So again, the rule of thumb, less than 185 over 110 prior to administration, less than 180 over 105 for 24 hours after the administration. We don't want to risk blowing out a vessel. With intra-arterial therapies, we don't have an optimal blood pressure that's known. RCTs have largely excluded patients who had a pressure greater than 185 over 110, so it's reasonable in the 2018 guidelines, they're telling us to use that as our guideline, so less than 185 over 110. Okay, what are our treatment choices for patients who are having acute ischemic stroke? Well, labetalol, 10 to 20 milligrams IV over 1 to 2 minutes, and we can repeat that times 1. If it continues to be elevated, then we can give 10 milligrams IV times 1, followed by an infusion of 2 to 8 milligrams per minute. We can also use, I will tell you before I move on though, labetalol is the gold standard here in terms of managing blood pressure in most patients who are having any kind of neurologic event. We want to maintain cerebral perfusion pressure, and really the guidelines say that labetalol is the drug of choice, or beta blockers. Other options include nicardipine, which is a calcium channel blocker at 5 milligrams an hour. We can titrate that to 2.5 milligrams an hour every 5 to 15 minutes for a max of 15 milligrams an hour. Clofidipine is another option. We can give that at 1 to 2 milligrams an hour IV, doubling the dose every 2 to 5 minutes to titrate to a maximum of 21 milligrams an hour. Other agents might be things like hydralazine or enalapril. And when we are reperfusing, we want to monitor the blood pressure every 15 minutes for 2 hours, every 30 minutes for 6 hours, and then every hour for 16 hours. So again, the new guidelines are pretty specific in terms of managing blood pressure. What do we need to do to maintain cerebral perfusion pressure and optimize therapies? Again, are less than 185 over $110 using labetalol. Sounds like good test questions. Temperature. Peak temperature in the first 24 hours. We want to keep them less than 37 degrees Celsius and greater than 39 Celsius. If we see these temperatures, we need to address them. So we need to maintain a good temperature for them. We have poorer outcomes if we're less than 37 or greater than 39. And we saw that in a retrospective cohort study looking at 9,366 patients who were experiencing stroke. These patients who fell out of these parameters had a higher risk of death. Hypothermia is a promising strategy, but unfortunately, it's not proven at this point. So unless the patient has had a severe ischemic episode that's been prolonged for an extended period of time, then you might put them on a cooling blanket or use cooling interventions. But really, in the acute phase, there's really no evidence that it provides much benefit just yet. Sources of hypothermia should be identified and treated. Antipyretic medication should be administered to lower temperature and hyperthermic patients who are having a stroke. This is not the time to let the immune system denature bacteria and allow the patient to be febrile. You want to control fever while the patient is in the acute phase. The benefit of induced hypothermia for treating patients with ischemic stroke is not well established, like I mentioned before. Evidence indicates that in terms of hyperglycemia, in the first 24 hours, if they're hyperglycemic, they're going to have a worse outcome. So what is going to be our ideal range for glucose in the stroke patient? It's 140 to 180. You do not want to bottom them out. Hyperglycemia is not good, but hypoglycemia is even worse. So if that sugar falls below 60, the patient has got to be emergently treated, and we got to get that sugar up. The range, 140 to 180, is going to be best. Okay, intravenous alteplase for cortical microbleeds. Clinically silent cortical microbleeds, we're going to call them CMBs here. About 25% of IV alteplase patients are experiencing these. There's been no randomized trials that have directly assessed TPA in those with CMBs, but data from 2 meta-analyses showed that ICH was more common than CMB, but not higher than INDST. Okay, this is just trials. Okay, so basically what the takeaway point is for this is that we can use IV alteplase for cortical microbleeds as well. IV alteplase can be beneficial for patients with sickle cell. I mentioned this earlier in the lecture that this can in fact be a cause of stroke. Case control analysis of GWTG stroke found no significant impact on safety or outcomes in treatment with IV alteplase among a large sample of those who had known sickle cell disease. So IV alteplase can be beneficial in strokes that are related to sickle cell disease. All right, in patients undergoing fibrinolytic therapy, you should be prepared to treat potential emergent adverse events. Those things are going to include bleeding complications and, even worse, something that can be life-threatening, that can cause immediate threat to life in terms of airway obstruction, is angioedema. Blood pressure should be maintained less than 180 over 105 for the first 24 hours after IV alteplase therapy. I talked about that. You don't want to risk blowing out the vessel and having a bleed. So keep the blood pressure under control. The risk of antithrombotic therapy within the first 24 hours following IV alteplase is uncertain, so use might be considered in the presence of concomitant conditions for which such treatment given in the absence of IV alteplase is known to provide substantial benefit. We'll talk more about that in just a few minutes. Dosing, you're going to dose it at 0.9 milligrams per kilogram with a maximum of 90 milligrams infused over 60 minutes, with the initial 10% given as a bolus over 1 minute. So 10% of the total, let's use that 90 milligrams as an example. You're going to give them in 1 minute 9 milligrams, and then you're going to give the remaining 81 milligrams over the next 59 minutes. All right, so hopefully that makes sense to you. Classifications and indications. Let's talk about this. This is important. So, like I said, there's two classes here. One is within 3 hours, one is with up to 4.5 hours. Let's talk about the 3 hours first. In terms of age, greater than 18, equally recommended for those less than 80 or those greater years of 80 that are under 3 hours. Severity recommended for severe strokes and for mild but disabling strokes. For class 2, so now we've extended it up to 4.5 hours. Looking at age, severity, and other considerations, the patient needs to be less than 80, without history of diabetes and prior stroke. They need to have a stroke scale score less than 25, not on any oral anticoagulants, and not have imaging evidence of ischemia of greater than 1/3 of the MCA territory. So those, as long as they fall out of those criteria, then we can extend that time of up to 4.5 hours. Okay, again, in terms of class 1, urgency, treatment should be initiated as quickly as possible. Time to treatment strongly associated with outcomes. Remember what I said, our goal is door to needle within 60 minutes. Blood pressure, again, less than 185 over 110. When you're starting IV alteplase, your diastolic's going to fall to 105 in the first 24 hours of therapy. Glucose recommended in otherwise eligible patients with a glucose greater than 50. CT scan is recommended in the setting of mild to moderate early ischemic changes. Again, non-contrast CT. Prior antiplatelets recommended in those taking single antiplatelet drug, and there's a benefit that outweighs a possible risk for subarachnoid hemorrhage, or I should say spontaneous intracranial hemorrhage. I apologize for the misnomer there. That's what SIACH is, spontaneous intracranial hemorrhage. End-stage renal disease, it's recommended in those with normal APTT. Those with elevated APTT might be at higher risk for hemorrhage. So all things to keep in mind in terms of eligibility. In class 2, so now we're going back to your greater than 3 hours, but not more than 4.5 hours. Your CT, not recommended if the CT shows hemorrhaging, obviously. There's insufficient evidence to identify clear threshold for hypoattenuation severity or extent that affects treatment response. So, like I mentioned before, you're not going to hold the IV alteplase unless there's extensive hypoattenuation. If they've had a stroke within 3 months, it may be harmful to them, okay? There's a risk for hemorrhage and associated morbidity and mortality, but it's not well established. So really it's going to be up to you in terms of weighing the benefit versus the risk here. In severe head trauma, it's contraindicated. If they've had any kind of brain bleed in the last 3 months, then they're not going to be a candidate if they've had severe head trauma. So head trauma within the last 3 months, we're not going to be giving them any kind of alteplase therapy. Intracranial or intraspinal surgery can be harmful within 3 months. History of ICH, potentially harmful in patients that do have a history of it. Subarachnoid hemorrhage, it's contraindicated. GI malignancy or GI bleed within 21 days, yes, they're a very high risk. If it's more than 21 days since the bleed, you're okay. Coagulopathy, I would know this. IV alteplase should not be administered if the platelet count is less than 100,000, the INR is greater than 1.7, the PTT greater than 40, or the PT greater than 15. All right, those are all very important parameters that you need to know, not only for your exam, but for safe treatment of your patients. If they've been on low molecular weight based heparin, if it was given in the last 24 hours, then they're not a candidate. Thrombin or 10A inhibitors, the use is not fully established, but it could be harmful, and it should not be administered in those taking agents unless no dose was given in the last 48 hours. Okay, so that's important. Thank you. Now I'm holding my sweet boy Max, my other schnauzer, in my lap, and he's giving me kisses. He's a sweetheart. Glycoprotein 2B and 3A should not be administered concurrently with alteplase. Infective endocarditis, IV alteplase should not be administered. They're at increased risk for rupture of the valves and possible hemorrhage. So we're not going to give it in cases of infective endocarditis. Aortic arch dissection, same thing. And intraaxial intracranial neoplasms. Unfortunately, IV alteplase can be potentially harmful for these people as well. So brain cancers, we're going to be avoiding the use of the drug in those people. In the extended 3.5 to 4 hour window, safety in patients who are greater than 80 and maybe as effective as younger patients, safe and beneficial in those taking Coumadin with an INR less than 1.7. I would know that. Maybe as effective in those who've had a prior stroke and diabetes, and may be a reasonable option. Severity, treating mild non-disabling stroke symptoms may be considered in both 0 to 3 and 3 to 4.5 hour window periods, but again, you have to weigh the risks and the benefits. The benefit of treating a stroke score greater than 25 in that 4.5 hour window period is uncertain. Pre-existing disabilities does not seem to increase the risk of spontaneous intracranial hemorrhage, but it may be associated with less improvement and higher mortality. But treatment still may be reasonable. Again, we're seeing that kind of come up as each one of these criteria, when we're looking at it, it's like, well, geez, what do we do? And my recommendation to you as someone who works in the medical malpractice field, follow the guidelines. If it says don't do it, could be risky, treatment may be reasonable, don't do it. CYA, guys. Early improvement treatment is reasonable if patients remain moderately impaired and potentially disabled. If they have a seizure, then residual impairments are secondary to stroke and not a postictal phenomena. It's reasonable if you think that. Again, blood glucose, those initially presenting with glucose less than 50 or greater than 400. Otherwise, you can treat them. Coagulopathy, safety and efficacy in those with bleeding, diatheses, or coagulopathy unknown, can consider it on a case-by-case basis. One of the things that you're seeing again pop up is this INR less than 1.7 or PT less than 15. I would know those numbers. That sounds important to me. If they've had a dural puncture, you can consider it if it's been more than 7 days. An arterial puncture, if again within 7 days at a non-compressible site. Recent major trauma within 14 days, not involving the head. Recent major surgery, again, if it's less than 14 days, then no, but if it's greater than 14 days, you're probably okay. GU bleeding, low risk if it's greater than 21 days. Menstruation, it's probably indicated without a history of menorrhagia. If they have a history of vaginal bleeding associated with anemia, then consult a gynecologist. Extracranial cervical dissections, reasonably safe and probably recommended within 4.5 hours. Intracranial arterial dissections, the usefulness is unknown. I would not give it in that situation. Unruptured intracranial aneurysms, like a small aneurysm less than 10 millimeters, yeah, you're probably okay. But if you have a giant or larger than 10 millimeter aneurysm, hell no, I would not give it. Intracranial vascular malformations, again, we don't know much about it, but because of the risk of ICH, I would stay away from that if they have a history of that. We already talked about cortical microbleeds, extra axial intracranial neoplasms. We talked about that as well. If they're also having an acute MI, treat at the cerebral ischemia dose, then coronary angioplasty and stenting if indicated. So fix the brain issue first, is what they're saying. Now, if they've had a recent MI in the last 3 months, it's okay if they're non-STEMI, but if they're STEMI, then really if they are left anterior myocardium, then you might have a contraindication. But if it's on the right side, then you're okay in a STEMI. Other cardiac diseases, pericarditis, if they're having a major stroke, it's reasonable. Pericarditis, there's an uncertain benefit if it's a moderate stroke. May be reasonable with a left atrium or left ventricle thrombus. Uncertain if it's moderate, but in major, definitely give it. In cardiac myxoma and major stroke, give it. Might want to give it if they have papillary fibrosarcoma and they're having a major stroke. Okay, so other recommendations here you can see for procedural stroke, for systemic malignancy, pregnancy, ophthalmologic conditions, sickle cell, illicit drug use, and things that mimic stroke. You can pause the lecture and read those on your own if you'd like to. Some are more important than others. Okay, so what happens if the patient develops this spontaneous intracranial hemorrhage after the IV alteplase? Well, I mentioned this just a second ago. If you are transferring the patient from the ED into the ICU and you've started alteplase management and the patient has gone from an NIH stroke scale rating of, let's say, 23 in the emergency department, and now they come in to the ICU and the rating is 25 and they're getting worse, then you need to be suspicious for the development of a spontaneous intracranial hemorrhage. What do I do? Obviously, stop the infusion immediately. Get yourself a CBC, check your coag times, get a fibrinogen level, and type and cross them. Get a stat non-enhanced head CT, get some cryoprecipitate on board, which includes factor 8. You're going to give 10 units over 10 to 30 minutes, and if their fibrinogen level is less than 200, then you're going to give them an additional dose. Tranexamic acid, we talked about this briefly in the updated lecture on trauma back in Unit 1, but you are definitely going to give that here, about 1,000 milligrams IV over 10 minutes, or you can give this EACA. I'm not very familiar with that. I'm more familiar with the TXA as an emerging therapy, but this EACA, you can give 4 to 5 grams over an hour, followed by a gram IV until the bleeding is controlled. You've already consulted hematology and neurosurgery at this point. Other therapy, of course, your blood pressure management, keeping the blood pressure under control. With what therapy? Hopefully beta blocker or labetalol therapy just came into your head as the gold standard. ICP, CPP, MAP, temperature, and glucose control all going to be vital. This is a rare occurrence when you're managing a patient with TPA, but guys, it happens. So the astute clinician that's doing prompt and frequent neurologic assessments is going to be the one that's going to catch this. So you want to make sure that you're that clinician. Other things related to general care with IV fluids, there is no evidence to support giving large amounts of fluids, so give them a euvolemic state if they're hypovolemic. Otherwise, you don't treat it. If they are hypovolemic and you don't treat it, this is going to exacerbate their ischemic brain injury. It's going to starve the kidneys and result in AKI, and it can potentiate the production of further thrombotic events. Hypervolemia can do some of the same things. It can exacerbate the ischemic brain by causing edema. Okay, and the other thing that it does is it stresses out the myocardium. So you already have a patient that has a history of, possible cardiovascular disease, and you're adding to that stress by giving them more fluids. So you can consider 30 cc's per kilograms of body weight as maintenance for fluid, for maintenance of hydration status, but unless the patient is hypovolemic, we are not going to be giving large boluses of fluid. Obviously, we're going to have to modify that if the patient also presents with SIADH, fever, CHF, other types of comorbidities. The other thing to remember, guys, is that when a patient is having a stroke, there are other there are other physiologic pathways that can be affected. So, for example, if the patient is presenting with symptoms that look like SIADH or symptoms that look like diabetes insipidus, then it could be that the area of the brain that's in charge of fluid regulation is being affected by the stroke. And once you clear the occlusion, the patient will have a resolution of those symptoms. Or it can be that, for example, you get a patient that has a severe stroke that affects the substantia nigra area of the brain, and that area of the brain infarcts. What disease process are they going to end up with? Hopefully, the answer is Parkinson's disease, right? So people can have strokes and end up with blindness. People can have strokes and end up with Parkinson's disease and other pathologic problems as a result of the injury and infarct that occurs. Other guidelines: tenecteplase, retaplase, desmoteplase, urokinase, some of the other fibrinolytic agents that you learned about in critical care pharmacology. There's really not enough clinical trial data to support their efficacy, so we really stick to alteplase. Tenecteplase does appear in the 2018 guidelines. If you're interested in reading more about it, there is a little blurb in there about using tenecteplase, but for this lecture and for our purposes, we're sticking with alteplase. Another problem, so we talked about spontaneous intracranial hemorrhage, but another problem that can occur that is maybe even more emergent is angioedema. And the reason why that is probably more emergent is because it can result in airway obstruction. So maintain the airway first and foremost. You may not need to intubate the patient, but if they're starting to demonstrate stridor and you're really worried about occlusion of the airway, go ahead and initiate your drug-associated intubation, or drug-assisted intubation, which is what they're calling it now, and intubate them, okay? Edema of the larynx, palate, floor of the mouth, or oropharynx with rapid progression poses a higher risk, so be on the lookout for that. Again, if the patient has stridor, immediately intubate them. Don't wait. Awake fiber optic intubation is going to be optimal for these people, so either having a pulmonologist or an intensivist nearby that can use a fiber optic scope and a bronchoscope to get that tube in is going to be the best. Remember, if they're getting alteplase, they're at risk for bleeding, so a nasotracheal intubation, they're going to have possible risk for epistaxis. Obviously, we're going to discontinue the IV alteplase, hold any kind of ACE inhibitor therapy the patient might be on, immediately administer IV methylprednisolone, 125 milligrams, 50 milligrams of diphenhydramine, and give them Zantac or Pepcid, IV, immediately. You can give them epinephrine, 0.3 cc's of a 0.1% solution, either sub-Q, or you can give them 0.5 cc's via nebulizer to further reduce the risk of airway obstruction with that angioedema. Agents used in hereditary angioedema or ACE inhibitor-related angioedema are listed here as well. Probably the most important thing for you to do: stop the infusion immediately of the alteplase. Give them some steroid, high dose, 125 milligram methylprednisolone immediately. Very, very important. Other therapies in terms of the guidelines: IV TPA is reasonable in patients with seizure at the time of the onset of stroke. I mentioned that just a second ago. Effectiveness of transcranial sonothrombolysis is not well established. And then that leads us to our endovascular interventions. There is intra-arterial fibrinolysis that can be performed. There's mechanical clot retrieval using a Mercy device. Acute angioplasty and stenting that can be performed. One of the most important things to remember is, even if they're going to get an intra-arterial treatment, you still give TPA. You don't hold the TPA and just do the intra-arterial therapy, whatever you're going to do, your intervention. You are going to, in fact, continue to give the TPA and do the intervention. All right, that's an important takeaway point. It's beneficial for major ischemic strokes that last greater than 6 hours in some cases, where we talked about some of the advanced imaging that supported that. But really, in terms of emergent therapy, where you don't have the advantage of that advanced imaging, the guidelines state less than 6 hours. So occlusions of the MCA are going to be really big in terms of endovascular intervention, and those who may not be candidates for TPA, those are also going to be patients that are going to get one of these endovascular interventions. Reduced time from symptom to onset with intra-arterial therapies is highly correlated with outcomes. Duh. Intra-arterial treatment requires an experienced stroke center and rapid access to cerebral angiography and qualified interventionalists. So not all centers are going to have the ability to do these procedures. In Orlando, obviously, Orlando Health Downtown, the big mothership, and for Advent Health, the big mothership that used to be called Florida Hospital South, or Advent Health South now, is going to be the main places where these types of therapies are going to, in fact, be possible. If they're going to pursue mechanical thrombectomy, they'll use a stent retriever like the Solitaire FR and the Trevo instead of the Mercy device. Thrombectomy devices can be used alone or in combination with fibrinolysis, like I mentioned. If they're candidates for fibrinolysis, they're going to get the TPA and they're going to get the endovascular intervention together. If they're not a candidate for TPA, then they're more than likely just going to get one of these endovascular interventions if it's less than 6 hours. No longer in the 28 guidelines is intra-arterial fibrinolysis or mechanical thrombectomy in patients who have contraindications to use of IV fibrinolysis. So the 28 guidelines did remove this particular recommendation. Rescue intra-arterial fibrinolysis is also no longer recommended in the 2018 guidelines, or mechanical thrombectomy may be reasonable approaches to recanalization in patients with large artery occlusions who have not responded to IV fibrinolysis. So again, the 2018 guidelines have updated these and these are no longer recommended for endovascular intervention. Other anticoagulants. Usefulness of argatroban or other thrombin inhibitors like 10A inhibitors is not well established. Usefulness of urgent anticoagulation with severe stenosis of an internal carotid artery ipsilateral to an ischemic stroke is not well established. Urgent anticoagulation with the goal of preventing early recurrent stroke, halting neurological worsening, or improving outcomes is not recommended. Urgent anticoagulation for management of non-cerebrovascular conditions, not recommended. and initiation of anticoagulant therapy within 24 hours of treatment of TPA is also not recommended. Obviously, that would increase the risk for spontaneous and serious intracranial hemorrhage, so we would not want to pursue those anticoagulants in patients who just received TPA. However, aspirin is okay. You can give aspirin at 325 milligrams within 24 to 48 hours after stroke onset. That is recommended in the 2018 guidelines. Use of Plavix and aspirin for 21 days, if started within 24 hours, can be beneficial in preventing stroke in 90 days. So, for example, a patient with TIA, starting them on Plavix therapy with aspirin can be beneficial at 21 days out. They've measured that as long as it started within 24 hours. Efficacy of IV tirofiban and eptifiabide is not well established. I'm not too familiar with those two drugs. Aspirin is not recommended as a substitute for other acute interventions. Yeah, we wouldn't want to say, you know what, you're a candidate for TPA, but we're just going to give you an aspirin. Nobody's going to do that. IV antiplatelet agents that inhibit glycoprotein 2B and 3A, not recommended. Aspirin or other antiplatelet agents as an adjunctive therapy within 24 hours of IV fibrinolysis is not recommended. So again, you need to be careful with that in terms of concomitant use with TPA. So the new guidelines do say that you can give oral aspirin within 24 to 40 hours after a stroke, and that is recommended in the guidelines. Volume expansion, some other information. In exceptional cases with systemic hypotension producing neurological sequelae, vasopressors may be prescribed by the acute care NP to improve cerebral blood flow. If used, we want to use close monitoring on a neuro unit, obviously. High doses of albumin is not going to be very helpful. Use of devices to augment cerebral blood flow doesn't help very well. Use of drug-induced hypertension does not help. Hemodilution and volume expansion is probably more harmful than good, so it's not recommended. And use of vasodilator agents like pentoxifylline is not recommended as well. So these are all coming right out of the 2018 guidelines. Neuroprotective agents, if they're already taking a statin, they're going to continue that therapy. Inducing hypothermia, we talked about that. We need more data. Transcranial near-infrared laser therapy is not helpful at this time. No pharmacologic agents with putative neuroprotective actions have demonstrated efficacy, improving outcomes, so they're not really recommended. And hyperbaric oxygen therapy, unless they have an air embolism like we mentioned earlier, not very helpful. Surgical interventions, emergent or urgent carotid endarterectomy, when clinical indicators or brain imaging suggest a small infarct core with large territories at risk, then they're going to get surgery, okay? If we have compromised inadequate flow from critical carotid stenosis or occlusion, they're going to get therapy. They're going to get surgery. Acute neurologic deficits, they're going to get carotid endarterectomy. So really, these things are going to be indicated if the patient is symptomatic with a large carotid plaque. They're more than likely going to get an endarterectomy. In patients with unstable neurologic status, so they're either a stroke in evolution or a crescendo TIA, carotid endarterectomies are not well established. So emergent or urgent carotid endarterectomy, when clinical indicators or brain imaging suggest a small infarct, you might see those done, but really, I don't know. I mean, my experience, they're going to do them, but to be honest with you, the guidelines say there's not a lot of benefit to them. Okay, in-hospital support on the stroke unit. Numerous studies demonstrate that stroke units reduce morbidity and mortality. We want standardized bundled sets to help ensure best practice, multidisciplinary teams and coordinated care right from the get-go, and CQI. Supplemental oxygen therapy, we already talked about this. It's not recommended in patients who are non-hypoxic. A new RCT with 8,003 patients, so a very large N, within 24 hours showed that O2 at 2 liters a minute if the SAT was greater than 93, or 3 liters per minute if the SATs were less than 93, at a continuous use for 72 hours for 3 nights, or nocturnally, I should say, for 3 nights, showed no benefit. So really, guys, unless the O2 SAT is less than 94, supplemental oxygen therapy is not beneficial. Blood pressure, we already kind of talked about this, but there are some concomitant comorbidities that require acute blood pressure lowering. We'll talk about those when we talk about specific diseases like aortic dissection. Excessive blood pressure and lowering can worsen cerebral ischemia. Lowering blood pressure acutely by 15% is probably okay. If the initial BP is less than 220 over 120, then reinitiating antihypertensive techniques is safe but not associated with improved outcomes. But if it's greater than this, then reasonable to lower it by 15% in the first 24 hours. In neurologically stable patients, it's probably safe to restart an antihypertensive if they're greater than 140 over 90. And obviously, like we mentioned before, hypotension and hypovolemia should be corrected. We already talked about temp. Basically, a new large sampled study showed that we want to keep them, but definitely not below 37, but not above 39. Hypothermia, we said, is promising, but we don't have any data right now to really support it. Therapeutic hypothermia right now is being undertaken in clinical trials. We talked about glucose really maintaining between 140 to 180. It is common. Hyperglycemia is common in stroke patients. It is worse in terms of outcomes when we have real high blood sugars, but like I mentioned before, not as worse as when you have less than 60 hypoglycemia. How do we correct it? IV push dextrose. Why not an oral agent? Think about that, guys. If the patient's having an acute stroke, then we don't want to possibly have an aspiration event because they could be dysphagic. So keep that in mind as well. Speaking of dysphagia, what about screening? Well, we want to do post-stroke. We want to do screening because post-stroke dysphagia can be as high as 78%. Obviously, it's a risk factor for pneumonia. In my clinical practice as a pulmonary critical care nurse practitioner, I see aspiration pneumonia all the time, particularly in my gero patients that have had strokes. And of course, it's associated with worse outcomes. With screening, we have insufficient data whether a screening protocol decreases death or dependency, but that doesn't mean we shouldn't be screening. So early screening is reasonable, and those who fail screening are usually going to be your older individuals with more comorbidities, those in SNFs, those that present with weakness and speech difficulties, have a lower level of consciousness, and have a higher stroke severity. Nutrition, stroke patients should be started on a diet within 7 days. In our food RCT supplemental diet, we had an absolute reduction in risk of death. A Cochrane review showed that PEG and NG feedings are similar with regard to case fatality, death, and dependency, but PEG was associated with fewer treatment failures, less GI bleeding, and higher food delivery. So PEG might be a little bit better than NG in terms of using that route to get oral nutrition. Oral hygiene may reduce the risk of pneumonia. Standardized screening and diet, along with standardized oral hygiene with antibacterial rinse with chlorhexidine, may reduce pneumonia in our stroke patients. For DVT prophylaxis, pneumatic compression stockings is going to be more effective. Primary outcome of DVT, we have 9.6% versus 14% in terms of those using pneumatic compressions. Benefit of prophylactic heparin, not well established. We just mentioned that it can increase the risk for ICH, so we would want to avoid either giving an anticoagulant like heparin while the patient received TPA therapy, or the other way around. If the patient received low molecular weight based heparin or any kind of significant anticoagulant therapy within 48 hours prior to presentation, then they would not be a candidate for TPA. Low molecular weight versus unfractionated heparin. Low molecular weight is once daily but more expensive and associated with increased bleeding in elderly patients with kidney disease. And elastic stockings should not be used. I'm guessing the reason why is probably because they're associated with higher risk for DVT in these folks. I'm guessing, I don't know. But definitely the takeaway from this is pneumatic compression is going to be best for these folks. New recommendation, it's reasonable to direct appropriate patients and families to palliative care. So it's important for us to recognize when patients have had such a severe stroke that the likelihood of outcome is going to be poor. Neurologically, functionally, refer them. Get palliative care on board, refer them out, maybe to hospice care, whatever we think is best in terms of at that stage of the game. Additional recommendations: avoid prophylactic antibiotics, avoid routine placement of indwelling bladder catheters. Texas catheter or condom catheter is probably okay, but when you put in a Foley, remember that just the procedure alone can increase ICP. Watch your skin assessments and perform good skin hygiene until their mobility returns. Treatment for acute neurologic complications: monitor for complicating brain edema and increased ICP. Measure to reduce during first days are recommended, so keep the head of the bed elevated, obviously. Early transfer to a neurosurgical expertise is going to be very important for those at risk for malignant brain edema. Decompressive surgical evacuation of space-occupying infarction or severe edema might be effective to prevent herniation or brainstem compression, for example. Decompressive surgery for malignant edema of the cerebral hemisphere is effective and potentially life-saving. Advanced patient age and patient family evaluations of achievable outcome states may affect your decision on that. Recurrent seizures after stroke should be treated the same way we would treat any other type of seizure. Place ventricular drain for acute hydrocephalus secondary to ischemic stroke as well. So we want to relieve that increased ICP, the increased brain edema, increased hydrocephalus, all the things that can result in brain herniation, we are going to decompress. So keep that in mind. If you ever work in a neuro ICU, you're probably going to be working with those types of devices. Although aggressive medical measures may have been recommended for treatment of deteriorating patients with malignant brain edema after large cerebral infarction, their usefulness is unfortunately not well established. Corticosteroids in conventional or large doses are not recommended for cerebral edema and increased intracranial pressure, which complicates ischemic stroke. And like I mentioned before, prophylactic use of anticonvulsants is a no-no. Wow, that was a ton of data. There were a ton of tongue twisters in that lecture for me, so forgive me if I had a couple of tongue twisters as I was going over that information, but it was a lot of very important data. I would not at all be upset with you if you had to pause this lecture and take a little break and get some Oreo cookies or some Chips Ahoy or whatever that you drink, maybe even an alcoholic beverage. Haha, I'm just kidding. Whatever it is to get through that lecture, it's a lot of information, and knowing that it's just part 3 of 5 is certainly daunting as well. Lots of information in this unit, guys. I appreciate your patience, I appreciate your attention, and I appreciate you. Always remember that. I'm on your side. I am your biggest champion in terms of getting you to cross the finish line, getting you through this program, and getting you to earn what truly is a very well respected credential of AG/ACNP in nursing. In closing, my name is Dr. Christopher Blackwell. Again, I'm an associate professor and the program director of the AG/ACNP programs in the Department of Nursing Practice in the College of Nursing at UCF. Hope you have a wonderful day. God bless, and bye-bye now. Please access Part 4 and Part 5 at your earliest convenience.